Hey everybody, welcome back to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm your host, Kylie Como, the legal nurse consultant here at Shane Smith Law. And today I'm joined again by Dr. Gilbert Mbeyo from the Brain and Spine Institute. Dr. Mbeyo, it's good to see you again. Our focus here is always to discuss all things brain injury. So Dr. Mbeyo, let's pick up our conversation where we left off last time. You mentioned the Triptans. Are those mainly like an abortive type of medication for the most part?
Good question. So it's a good question. In this context, that'd be what we call headache abortive medicines. Talking through that, so think about therapies for headache broadly falling under preventative therapies. So those medicines that reduce the frequency, the intensity of these headaches. So there's the preventative therapies, typically taken daily for prevention. And there's a class of medicines, we'll talk about those ones, but the preventative medications. Then we have a class called the abortive therapies. So the headache abortive therapies are what will be taken to stop that headache at its early stages or it's built up to that really intense headache. So the abortive therapies. And the Triptans are within that class of abortive therapies. Some of the other new abortive therapies are within a class that we call CGRP. So the CGRP medications. And these are quite interesting. The CGRP class of medications, certainly for many years, all we had in our toolbox was the Triptans for abortive therapy. And as we understood more and more about the pathophysiology of these headaches, about how do they develop and how do they progress and what parts of the brain are affected and what neurotransmitters are affected, what peptides are responsible or neuropeptides, we started to understand that a certain neuropeptide, CGRP, calcitonin gene-related peptide. So we started to understand that that is key in the pathophysiology of these headaches. And so medications that block or antagonize CGRP, quite useful in both preventative and abortive therapy. So now we don't only have Triptans, we also have a host of CGRP medications. I'll give examples. Ubrelvy is again brand name. Ubrelvy becomes one of those ones where we have what's called Nurtec, another brand name for one of these CGRP medications. We have Ajovy. So we have a host of these CGRP class abortive medications. And so we used to only have the Triptans, and they still have use in some patients. But now we have a few more we can utilize in this subset for abortive therapy. The CGRP class is what we call it, and some more in the pipeline.
Yeah, the medications, that have come such a long way when it comes to treating, age or just persistent migraine. Some of these can be a pill like the Triptans, but then some of the other like the CGRP, those are more or can be more infusions, right? That a patient might have to go to an infusion center or maybe in your office to receive those sorts of things. So
the CGRPs lend themselves to different routes of administration. So as you point out, there are some that are infusion-based therapies in the neurology office. We do offer those. There are some that are injectable, almost in the form of an EpiPen. So just imagine what an EpiPen would look like, and it could be either as an abortive strategy, so a headache coming on and it's trying to build up into that really intense headache, an EpiPen-like administration. So right under the skin would be another way that it could be administered, so injectables. The CGRPs are also quite interesting because there are some intranasal, so intranasally administered. So for those who would not like a pill and so those who wouldn't want an injection, there's also that nasal administered option of a CGRP class. Zavspret is the name of that the brand name of that CGRP medication. So nasally administered, with more in the pipeline. There are actually CGRP pill formulations, so oral disintegrating pills. Several options in that CGRP class. And then interesting is that the CGRPs are not only helpful in that abortive strategy, so making that headache go away. We also have new CGRP medications that are quite useful in prevention. So could be taken on a daily basis. So if this was an individual that told me, Dr. Mbeyo, out of a 7-day week, I'll have 3 to 4 days where I have these intense headaches and maybe some other headaches beyond that, but then 3 to 4 intense headache days. That's about 16 headaches a month or 16 headache days a month. Reasonable to think about a preventative strategy. In the past, if we were taking that preventative strategy and again, understanding that the post-traumatic headache is more of a migraine phenotype headache, our preventative medications were many. Tricyclic antidepressants is one class of medications we could use. We could use a certain subset of anti-seizure medicines that, interesting, also have an effect on preventing these headaches. We've got blood pressure medications that also have a role. Propranolol comes to mind. Blood pressure medications that were designed as cardiovascular directed medicines, but also have an effect on headache prevention. CGRP medications also have formulations that are quite useful as daily or sometimes monthly injectable preventative medications. So this has really helped us talk about why it's important to carry out that phenotype assessment. What type of headache is this? What's it behaving the most like? And then as we understand that helps us understand what are our treatment options, both abortive and preventative.
That is a fantastic rundown. There are, you're right, so many treatment options and can be so uniquely tailored. That got me to thinking, though, you mentioned propranolol, for example, it's a heart medication, it's a beta blocker, but we found uses for it in this migraine realm. So that gets me to thinking about FDA approval, right? So there's still a lot of barriers, if you will, still a lot of limitations when it comes to FDA-approved treatments. And so why is that?
We don't have many studies looking at medication options in the post-traumatic brain injury setting. So majority of them, in fact, all the medications we use will be off-label. So again, underlines that importance of a phenotype assessment. What does this headache behave the most like? So we don't have direct, they are ongoing. I mean, there are some clinical trials that come to mind looking at options and hopefully leading to the pathway of an FDA-approved pathway or FDA-approved medication for these post-traumatic headaches. For now, we must borrow from our other headache syndromes. But let's go even further. Many of our headache medications are used off-label. So FDA off-label doesn't mean that they're not effective. It just means that the large randomized clinical trials looking specifically at that medication in that particular headache syndrome, maybe that wasn't performed and doesn't mean it's not effective. Many of these medications have many decades of clinical use in these settings. The FDA approval could have been for blood pressure control for that medication, but we found that it can also help prevent migraines or prevent headaches. Or the FDA approved indication could be, for example, depression treatment, like we call them the tricyclics. And what comes to mind is nortriptyline. So the FDA approved indication would be for the treatment of depression. Doesn't mean that it is ineffective in headache prevention. We're just using it off-label. So many examples of off-label uses. Caveat, off-label does not mean ineffective. Many of our medicines, even some of our antibiotics, are used in an quote unquote in an off-label manner. Perhaps that approval was pursued, and it's quite an expensive process to pursue FDA approval. And so perhaps what we end up doing is borrowing from clinical data and then just over time the use cases that have come up over time. So FDA approval, quite a consideration. I'd say perhaps the CGRP classes do have that FDA approved stamp for migraine, both abortive and preventative. But again, as we use them in the post-traumatic brain injury setting, that post-traumatic headache setting, where we're using them, call it off-label, knowing that the phenotype of the headache is like migraine. And since it's like migraine, we could use a medication that is useful in the migraine setting, off-label, but again, really important to carry out that phenotypic determination of the type of headache.
Being able to get to that FDA approval, if you will, it is costly, it is time consuming, it involves that, making sure that we can standardize a particular treatment, but there are, again, a lot of barriers to that, So can you talk about what might be some of those big barriers to standardizing treatments?
Quite a few that would be barriers to standardizing our approach. Perhaps one is just how different presentations in that traumatic brain injury setting are. So the presentation is just so diverse. There's no one distinct presentation for traumatic brain injury. It's again, many things can cause traumatic brain injury. It could be a direct blow to the head, maybe a fall from a height, and sometimes we'll say a baseball bat right to the head. So that's one mechanism. Another mechanism could be blast-associated traumatic brain injury. Acceleration and deceleration forces. For example, in an auto accident, that acceleration, deceleration, and torque that the brain gets subjected to. So many pathways leading to a certain process, but even then, this neurometabolic cascade is so different in so many people. One of the challenges to having a direct standardized approach, similar to what we would have in essential hypertension, so blood pressure controls, a little more standardized in how we would approach it. In this traumatic brain injury setting, so many things that can cause traumatic brain injury, so many variations in that neurometabolic cascade that triggers so many presentations situations in terms of the complications or the post-traumatic brain injury manifestations. It's just so varied. And then that becomes one of those barriers to a very standardized approach to helping these patients out. That FDA approval process, as challenging as it is, again, just being challenging, not only because of the magnitude of expenditure that goes into really well designing, performing it, conducting that massive clinical trial, well analyzing that. So a lot of resources going into that. And I'd say, let's watch this space. I think we're now paying more attention to call it mild traumatic brain injury. I say call it mild traumatic brain injury because I'm one of the proponents that our classification of mild, moderate to severe, certainly we need to change, and that is changing. But again, now we're looking harder at traumatic brain injury consequences. So we're paying more attention to it. So give it a few years and we'll start to see more effort in trying to identify treatments, identify pathways for medication strategies and things of that nature. So we're still early. I think this had been a hidden, really ignored injury. So that hidden injury was one of those things. And again, just not many people making that connection between, well, the injury I suffered a year ago, 2 years ago is the reason why 2 years later, here I sit in the doctor's office with this relentless headache, or I used to have migraines and now I have, and it was once, maybe every few months. Now it's several times a month and things. Just not making that connection. As we get more educated, as clinicians really understand this disease process, as clinicians understand, as we all understand as a society, that traumatic brain injury is significant, not just acutely, but can have many long-term consequences like headaches. So as we understand that more and more, we'll start to look harder at what can be used to treat the complications of this devastating condition. So watch this space. I think the future is bright as far as recognizing and identifying treatments for traumatic brain injury, including headaches.
Yeah, agree. I think it's such a quickly growing field. I'm glad you brought up, the mild TBI and how that may be somewhat of a misnomer. I think, it depends on who you ask, right? But the availability of quality research is so much more today than we had maybe even 3-4 years ago. So I agree. I think this space is going to be blowing up for the next few years, and we're going to see some amazing advancements. Speaking of, advancements or emerging treatments, we see a lot of them. I've seen a few of our clients even coming through having received Botox injections for these chronic kind of migraines. So tell our listeners about, those types of kind of novel and emerging treatments, and Botox in particular, if you could.
Excellent. And so that takes us into the realm of what we call interventional pain management procedures. Interventional procedures being rather than, pill-based strategies or, medication strategies in that manner, now procedures that we can use to alleviate many of these headaches. Botox is actually one of the ones that really excites me as an option. And whenever I bring it up with my patients, they say, well, Dr. Mbeo, are you saying that I've got wrinkles? I say, no, not at all. It's the same toxin, it's Botox, but we're using it for a different purpose. So beyond the cosmetic indication, Botox is actually widely used in many neurology practices, including my own, for chronic migraine. So Botox is quite a useful intervention that helps in many of these headaches. So if again, we understand that post-traumatic headache has taken a migraine phenotype and behaves just like a chronic migraine, using Botox, and this is carefully administered Botox into some carefully studied locations in the head and the neck area. So using protocols that are well studied, well designed, well recognized, Botox certainly is quite useful. And it has many mechanisms. And perhaps one of the ones that we rely on the most is Botox is blocking the release of these pain conducting fibers, release of neurotransmitters. So quite useful in that manner. Botox also has that effect on muscle spasticity, muscle tightness. So not unusual for these patients to come in with a temporomandibular joint. We call that TMJ, associated spasm, and headaches now becoming prevalent because of the spasms in those muscles, the TMJ muscles, the masseter and the temporalis muscles, and muscles behind the head, the occipital muscles, and the cervical paraspinals is what we call them, and also the trapezia. So many muscles that go into spasm and now are in this relentless headache causing cycle. Botox has an effect on those muscles. So every 90 days, we would typically repeat it. And the goal is to get from this really daily or frequent headache cycle to perhaps reduced frequency and intensity, and hopefully get to a place where no headaches, or so reduced that we can now back away from use of Botox.
That's fascinating. Yeah, we're like I said, I'm seeing that more and more even amongst the clients in our firm. Another one that I find particularly interesting just because of its route of administration is the sphenopalatine ganglion block. I love to say the word, and the treatment itself is fascinating. Tell us a little bit about that.
Interesting route of administration. So the sphenopalatine ganglion, so a ganglion is a collection of neurons or neuronal bodies. So a collection of neurons. And so if we're going to think about some of the relays, some of those areas where pain transmitting neurons in the head and the neck, where do they relay? So one of them is the sphenopalatine ganglion, that final common destination that is part of this headache pathway, the sphenopalatine ganglion. Why is that important to understand? Therapies that will calm it down or calm down these ganglia, so SPG is just one of them. Think about in the same manner as hitting the reset button on a computer. So you're really trying to hit the reset button on these overly sensitized head and neck neurons. And a good target is the sphenopalatine ganglion. Now, the way to get to it, there are a few ways to get to it. One way to get to it is using a certain device called the sphenocath. And there's other devices, but a sphenocath comes to mind as one of those devices. And we're trying to carefully pass that catheter, that carefully designed catheter, through the nasal passage, so all the way through the nasal passage to the back of the nasal. We call it the turbinates, so around the level of the nasal turbinates. So the back of the nasal passageway is where we're trying to direct carefully this sphenopalatine ganglion. It's not a needle; it's a soft tip catheter that just helps us maneuver that pathway and get us close to that ganglion, that collection of of neurons. Why we are trying to get there is to be able to deliver a medication, usually a local anesthetic medication. So we get to that ganglion carefully and then deliver local anesthetic medication, usually lidocaine or 2% lidocaine could be what we would use in that setting. And we do it in one nostril and the other nostril. So each nares would be where we would pass this phenocath and deliver that lidocaine. Again, what we are trying to do is to hit the reset button. Typically, when that is performed, it's performed in office, so not a surgical procedure by any means. It's like I said, a soft tip catheter that's carefully directed by a trained individual to that ganglion of neurons. The treatment's well tolerated, takes a few minutes, and then if we need to repeat it based on effectiveness, I'd say every 2 to 3 months would be reasonable to repeat it. Think about it. These are individuals that are afflicted with daily headaches, that nothing is helping, and their new life is day and night living with some degree of a headache. Now, with this phenocath, we're able to reduce the frequency and the intensity. It's an uncomfortable procedure, but tolerable.
Quite an interesting approach to relieving pain. I think another related, we're kind of talking about blocks, kind of stopping that pain signal. Another one we see quite a bit that I know you're quite familiar with, that occipital nerve block, right? Kind of a different area of the anatomy, but how does that fit into your treatment regimen?
So quite a helpful procedure as well in many headache clinics, including in my own clinic. So the occipital nerve block, I'll put that under the blanket of nerve blocks. Perhaps the most common nerve block in this setting would be the occipital nerve block. So when I describe it to my patients, I tell them that it's the back of the head nerve, the occipital nerve. So that nerve that gives sensation all the way from the back of the head to the occipital area to the vertex. And this nerve exists bilaterally. So we've got a bilateral occipital nerve, the right and the left occipital nerve. And then the occipital nerve also divided into a few branches or made up of a few branches. So the greater and the lesser occipital nerve and the third occipital nerve. So different nerves that give sensation to different parts of the scalp. But we talk about the occipital nerve, as almost that blanket name or the blanket term for this nerve. Now, why would we perform a nerve block in headache alleviation? Many times within that headache history, as we talk to patients who have these daily headaches or these refractory cephalgias, we call them, these head discomforts, there's a description. It comes from the back of my head and comes wraps all the way up to the front. And there's this one area that it's quite sore. Sometimes they'll know it. Or my scalp is really sore. So whenever the headache comes on, I can't even brush my hair. So my scalp becomes really tender, really sore. And on exam, exam, so when one conducts a neurologic exam, one of the places I usually will go for is to try and palpate the occipital nerve, and that unfortunately makes them jump, and I usually apologize because that nerve is quite sensitive. Now, an occipital nerve block is a nerve block procedure that allows us, again, in the clinic, sometimes using ultrasound guidance, sometimes using that traditional landmark approach where we're just feeling landmarks in the skull to guide us to where the occipital nerve is. We use those landmarks or ultrasound to gently guide a needle to where the occipital nerve is. With that, deliver a dose of local anesthetic medication. Same effect. The goal is to hit the reset button. There are other cranial nerves, or cranial sensation nerves that we could target in a similar manner. Supratrochlear and supraorbital nerves, and we could block them in the same manner. So again, some of my patients that would come to see me in the setting of a post-traumatic headache that would say, well, Dr. Mayo, I've got that back of the head nerve sensation, but I also have this headache or this sensation right above my eye or right in my eye. That gives me a clue that the supratrochlear and the supraorbital, the above the eye nerves, have become sensitized. And that's also an opportunity for an interventional procedure. So a supratrochlear, supraorbital nerve block. So again, using local anesthetic to hit the reset button on the nerves. We also have a nerve right on the temple. We call it the auriculotemporal nerve. So another nerve that subserves sensation and can go into overdrive in this headache. And so an auriculotemporal nerve block, quite useful in these patients also for the same reason, hitting the reset button. And sometimes I'll combine all of those. So depending on the pattern, the behavior of the headaches. So those nerve blocks quite useful. Where the nerve blocks can lead us, if in some patients, I might determine that, well, the nerve block works, it perhaps doesn't last as long as we would like. Maybe a few months in the first one, maybe a month in the next one, and maybe a few weeks in the other one. It tells us that the nerve is sensitive. It just tells us perhaps let's find a strategy that makes this last longer. And there are different things we could do. So again, targeting the same nerves, performing an ablation procedure. What's called a radiofrequency ablation becomes an option. So an ablation procedure to put those nerves to sleep for a much longer amount of time, 6 months to a year. Cryotherapy is another one that I use, using a device called iovera. Iovera is a cryotherapy device, well studied, useful in helping with knee joint pain. That's why it's been the most studied. But I've also used it, I'll call it off-label, for cranial phalgias. So occipital nerve, if the block worked but didn't last long, could use cryotherapy using iovera or similar devices to put those nerves to sleep for longer, 6 months to a year.
The palette you have available to treat, the options, if you will, that your patients have available. If one thing doesn't work, oftentimes with medication, you switch to a different med, but that is fantastic. I know our listeners may be thinking, well, that sounds like a lot of needles or, catheter in the nose, but there are some completely non-invasive treatments as well. And the one in particular, I know you do quite frequently, I believe, in your offices, the transcranial magnetic stimulator. How do you guys use that for treating PTH?
That's a great question. And I'm actually seated in my TMS room. So you can't see the TMS machine that sits right behind me.
Yeah.
But quite a robust tool that we can use. In fact, let's see if I'm able to bring that a little closer. So transcranial magnetic stimulation. So we use a certain device with that delivers pulses of magnetic energy to certain parts of the central nervous system, usually the brain. The same device can be used for peripheral magnetic stimulation to reduce sensitization of peripheral nerves. So transcranial, when we use it in that transcranial manner, so different parts of the neural axis of the brain, and then we can use it for peripheral magnetic stimulation to stimulate nerves that are on overdrive, again, to try and help calm them down. So TMS. So quite a useful therapy. It's non-invasive, as you point out. So non-invasive, therefore perhaps more accepted by a patient that prefers not to use medications, prefers not to have needles or catheters in the nostril or needles around the head, and they still have this affliction with a daily headache. So TMS has good research-backed data in its use in helping with these post-traumatic headaches. So a session typically lasts about 30 to 45 minutes, 10 back-to-back sessions, and even longer. So longer, up to 30 to 36 sessions. Quite a useful tool. And as the years go by, you start to see us as clinicians using TMS and what we call neuromodulation approaches. So approaches to control or to regulate dysfunctional neurons. It's not electroshock therapy, it's gentle pulses of magnetic energy to speak the language of neurons and to try and calm down these dysfunctional neurons that are on overdrive. So I like that you bring that up.
That was great. I always love talking to you because you're just such a wealth of information. Is there anything else, Dr. Mbeo, you want to talk about? Any additional things that came to mind? Or
I think we've gone through this topic pretty well, and certainly not in an exhaustive manner. We could talk for days about post-traumatic headache. I think a good place to begin, if one has that thought process, could what are the solutions? What are the options do I have? Speaking with a neurologist certainly will help shed light. Just as we've had this conversation, so many neurologists are aware of these tools' availability. So speaking with a neurologist to talk through options, someone who's willing to take that detailed history to understand and to come up with good treatment options. So certainly that's a good initial entry point, and then certainly that individual, that neurologist is well capable enough of identifying potential solutions or therapies that we could try in these refractory headache syndromes.
All right, everyone, that's going to do it for another amazing episode of Mind Matters, Navigating Head Injuries and Concussions. Again, I'd like to thank Dr. Mbeo for joining us today and sharing his vast knowledge and his passion with us. I hope that our audience has really enjoyed being a part of this great discussion as much as I have, and is walking away with a better understanding of some of the resources available to them and some of the cutting edge and novel treatments being used to diagnose and treat brain injuries. Please don't forget to hit that like and subscribe button to keep up with our channel, and leave us a comment to let us know what you thought of today's conversation. As always, remember, if you're in pain, call Shane at 980-999-9999. We'll see you next time.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.